you to our panel for all this input. And we'd like to kind of open up to everyone now to kind of discuss this. I think we've heard a lot of kind of different aspects, and really this isn't necessarily meant to discuss end of life, but that is one of the parts that comes up in a phase 1 program. Our goal is still, while everyone who's multiply relapsed neuroblastoma, there is no curative option that we know of, and it's that we know of is an important part of the conversation, because that is what we are trying to find. That's why we're doing this research. That's why but at the same time, we want to make sure that we are holistically caring for the patients and caring for all parts, and really understanding as physicians what the goals and objectives of the families are. Some families want to push for more intensive therapy and really trying to push for that immediate cure. Some families want to maintain quality of life, yet still trying to keep their child's disease stable, turn neuroblastoma into a chronic disease, live as long as we can with good quality of life as we can. And really, how do we as physicians work best with families to find that, have those discussions and make sure that everything's open and understandable to not only our team but to the oncology team that's sending us the families, and make sure that everyone is on board with that. And how should these discussions be happening? I'd love to hear from the families and physicians and researchers out there that are taking part in these discussions.
Hi, my name is Mike. My daughter's name was Saoirse. She passed away at neuroblastoma back in 2007. Annabeth, you're like one of my heroes right now. You're an amazing person, and thank you very much. And really the whole panel. Quality of life is very, very important to us. We were told when Saoirse relapsed, basically, that she was going to keep getting better. And I'm not joking about that. We were 2 days before she died. She's in ICU, and we were told she'll come out of this. This is going to be fine. We've seen this a lot. And she was dead 2 days later. So we had no preparation. We know the outcome, but I thank you for getting together and just all of you as a group and trying to make this work, and make parents feel a little bit more comfortable and not surprised, because that's horrible. And doctors need to know, and I'm just going to kind of go on yours for a moment. We're very educated people, and when a doctor comes to us and tells us that their way is the only way or is the highway, I take very, very big issue with that. And it took me threatening CNN with our doctors to actually get something done. And I had a lot of friends at CNN, and that would have definitely happened. And that hospital chose to talk to us instead of kind of put a wall up. Now, the other thing that I think is really, really important is nutrition. And I was really happy to hear that you're here, and I'm curious to see or to hear what some of the doctors say about nutrition and a plant-based diet versus an animal protein, and how that could help possibly in building the immune system in some of the therapies you're doing, and building the immune system in some of the aftercare while children are going through the chemotherapy. We were told very clearly that it doesn't matter what we feed our kid, and the hospital we were in, there was nothing on that menu that really builds the immune system. It was all fried and processed foods, and a lot of sweets and a lot of treat trains. And I get you have to make kids happy. They're in a crappy situation. But I wanted my kid to get better. So we brought our own food in. They weren't happy about that, but I didn't care. It's not their kid. That's my child. So we brought our own food in, and it helped her. It didn't save her life, but it gave her a better quality of life. So I'm really happy to hear that you guys are working together, and anything that we can do as a foundation and that we can do as parents to give you support with that, we're with you. Because as a parent, you want to get your child better. That's all it is. And you don't want to listen to doctors that are closed-minded, and we don't. And I don't feel that with anybody here, which is why we try and support you as much as we can. You guys are very open-minded, and I think that that's key, and that's where this has to go. You have to be open-minded and try different things. So I thank you for that. And so I challenge the doctors that are here, and the nurses, and the nurse practitioners, look into nutrition. Don't close a book. Think outside the box when it comes to nutrition and trying to help build the immune system and helping people get better. Because maybe it will, maybe it won't. I don't know, but no one's going to know until we try it and we incorporate it into this treatment somehow. So anyway, that's all I have to say. Thank you very much.
name's Jennifer. I'm a nurse. You know, I think it's awesome that the doctors and the nurses and the parents are speaking, but more importantly, I think about, because my background is child life, and I think about what the kids go through, and I think about the stress of everything we have to endure. And so I really think an important part of this process is to incorporate the kids' perspective into their therapy and their treatment, and giving them an outlet to express stress, or giving them an opportunity to make a difference in their own care. You know, I saw that it had patient preferences on there, but like, I think the kids really need to have a voice in what's being done to them and feel like they have some control over their disease and their ability to get better. So, I mean, I just, want the kids to be represented. That's what I'm saying here as well.
I'm wondering, Deb, are there any tools out there to kind of check in with the kids and
Yeah, we like to tell the parents that it's the kids' ship. They're leading the way, and we take our keys from the children. When parents are, as the guardians, are able to make decisions, we ask them to make decisions for the sake of the child, from the child's point of view, rather than what they want as a legal guardian.
But like kids, like the parents are part of a family and it's dynamic, and they may not agree with what their parents say, whether it's one or two parents they don't agree with. There's still, some validity to it, that they know more of what they're going through than what their parents do. I consider mothers like the first doctors, and then I consider the patient like the number one, when it comes to treatment decisions.
I think part of the problem is that average age of diagnosis is 2, correct? It is very hard. I mean, that presents two kind of conflicting things. On the one hand, a 2 and 3-year-old child doesn't care about egos, doesn't care about hospital politics. They just want to feel better. They don't care about all this stuff that other people have to think about. But at the same time, they're also not so great at expressing anything else besides, ow, this is crap. Fix this. And that sometimes makes it really hard. I mean, that was definitely an issue that we struggled with a lot, was we knew our son was in pain, and an extreme amount of pain, but it was very hard to say where it was coming from and then what was causing it. And, I mean, you're just...
Right. But see, like, at 8 years old, they can get sent to treatment, and at 8 years old, if they have no vessel when they're younger, they are old enough to understand what they're about to endure, especially if it's relapse therapy. And I'm just saying, if they can assent to therapy, then they can also give us insight into how they want to be treated.
I think I liked one of the pictures that you see often with integrative medicine that Dr. Schiff showed, which is really a continuum. And I think that's a little bit of what's brought up here, is that it's a continuum of development. Whether you're the young patient, the young adult who's sort of been taken off their typical path to independence. And it's incumbent on everybody that's advocating for that patient to figure out where in that process they are, to help keep that journey kind of balanced between all the needs, not just in this. And I am so sorry you had to deal with arrogance, because if there's anything that makes me as a physician humble, it's all the things we don't know about cancer. And it's all the things I am amazed at by how the families go through this on a regular basis, and you do so well, and you show such strength. And you know your kids better than us, and you know how to help them move around. And yes, sometimes there are total needs from our child life, and that's why it's not just a one-person team. It's a huge team that says, hey, I think this child needs a space of their own to make some of these things made known in a developmentally appropriate way. At the National Cancer Institute, we see probably more often the adolescents than the young adults. And we have just helped to develop a Voicing My Choices guide for adolescents and young adults. It's free through Dignity. I'll have to look up the website. Aging with Dignity. They have a hospice manual that's available free for adults. And we adapted it for the adolescents and young adults, and are working on ways to sort of, how does that fit into younger patients? Obviously not quite at the 2, but developmentally correct. to allow their voice to be a part of it. And I think getting at exactly what you're saying. And how do you include that in your palliative role or even the naturopathic role? How much of a say does the child have, and how do you figure out how to include that in there would be my question to the parent.
The child life plays a hugely important role, speaking to the child in a developmentally appropriate way so they understand what has happened, what will happen. We have a saintly art therapist that works with the kids and gets them to express their feelings, and she'll if she feels a child's going through something and needs more help and support, she'll let us know. Obviously, they need to agree to the therapy, that we're not doing something to them. We're sort of working with them to help them get better. So they're included in the therapy.
I look at it as a buy-in. You know what I mean? If you get somebody to buy into what you're about to do, you're going to have a better outcome, you know? Mm-hmm. And I think kids do deserve to have a little bit of control over what's happening, you know? And if they have a buy-in, if they feel control, then that gives them more strength to endure and to move forward and to really champion their own disease.
Agreed.
I mean, that's just the way I feel.
Mm-hmm.
I think
That's a
that was
good point.
definitely highlighted when Lisa got talked about. She was very into her treatments and she took control of that, and I think that definitely had to have, my guess is it had to have helped her psychologically in getting through what she was going through. And even my daughter was 18 months old when she died, but she knew what was going on. There's no doubt in my mind. And I had to, you know, I think what helped us was, as a parent, you really focus on everything that's going on around your child and what they're going through in treatment. And you learn to see the signs, and you learn to see the face expressions. And that was her voice to us, and that's how we interpreted it, and that's how we would communicate with our doctors and nurses, mainly the nurses. Sorry, but they're the ones that took care of my daughter. You know, it's nothing against anybody, but we would teach the nurses how to read her communication. I think that really helped a lot. So I agree with you, absolutely. I mean, you really have to focus on the child too. Parents as well, but the children are the ones that are going through this.
My name is Tina, and actually, right now my son is under Dr. Eslin's care. Hi, Jennifer, you too. But we've been now at 4 hospitals, like many families, and our first one, Children's in Minnesota, we had a wonderful experience, and all the things that we're hearing, I'm realizing how fortunate we were. And I just want to share the things that made a difference to us and our family, not just the patient, but the family. And let me just say, too, we're receiving excellent care from Dr. Eslin and his team, too. But our doctor, Dr. Susan Sensor, she was also the chief of staff at the time, and I think she still is, but they, in our experience, had a very integrated team, and we had direct access to what they called the pain team from the get-go. And we would have those conversations so that throughout each stage, because we know as parents that it just shows up in a whole different way each stage as you're going through, as their skin's peeling off, as they're vomiting, everything is new. And we could talk to them and say, this is working, that's not working, and they would respond. On the antibody therapy, I remember the first round, my son looked like he was getting electrocuted. I mean, it was terrible to watch. And it's unfortunately not uncommon, as I hear a lot of parents' stories. However, after that, I got on the internet, we researched different things. I talked to the pain team and I said, hey, I was reading about this thing on pain stuff, because he went on morphine. He did all the things that typically are done, but it was just like he was like a strung out drug addict by the time we got to the second time, because we were kind of overcompensating. And I said, hey, I've researched this, I've learned this new word, apoptosis, and I've also, I'm just coming up with this stuff. I'm no researcher, but I say, it says that ketamine might, also contribute to this. Is there something we could try with this? And we tried this kind of low-dose ketamine in the back, and the pain team really worked on this. And the next round, it was like he was watching his favorite cartoon. I mean, it was, that example of teamwork was unbelievable in the quality of life for him, for us, and really the entire family, because we had more energy, we could go back out and be with our well kids in a different way. So that was one thing, as an integrative pain team, made a huge difference in introduction at the beginning of the process. A second thing was use of whatever you want to call it, alternative medicine, integrative therapies, etc. On site, there were massage therapists, music therapists, healing touch, and during my son had a double stem cell transplant. There was a time when nothing was working. There was no pain team at this hospital that I could have direct contact with, and the only thing that helped is when a nurse said, "I've just heard your son crying, all night. I'm not your nurse, but one of the other nurses said, can you go in there? I do healing touch. Do you mind if I try it?" And it's the only thing that gave him some peace that night. So having the access to things that some people think are outside the box, and I understand that some people are not comfortable with that, but for us and for most parents, all parents, we just want to do whatever we can to give our children comfort, and to have the access of it, to have it not be looked upon as something kooky and crazy, and now you're demanding all these different things, and to be really integrated as a part of the team, an educated part of the team, a person who, most parents can look at their child and know the difference between a turned up side lip and a, down, like, we know degrees of pain after holding our child, vomiting all over us, doing all of those things. And so to listen to parents, and sometimes you have to read into it because sometimes we just don't even know what you say, but the nurses and the medical professionals that can really slow down and take it all in and really listen and be open to all of those things have made the biggest difference for us. So I just wanted to share that in terms of things that have helped. And thank you all for for everything you've done.
Well, we'll get ready for the next question. I actually want to ask you guys in the audience a question. We have a lot of families here and in different stages of what's going on from your journey, whether end of upfront therapy, in relapse, or whether your child has already passed away. Can I see a show of hands of families who actually got some input, whether it's just from a pain management or true palliative care, whatever it was called, at upfront diagnosis? So not very many. How about at first relapse? Again, not very many. So really, where did it come along? Was it really not until therapies were no longer being discussed? How many there? Second relapse, okay. Where should it come?
Day one.
You want to give parents hope, obviously,
Right.
But once parents go home and they start researching, and make no mind, we're not researching the goofy sites. We're researching your sites. We're researching your protocols, not the weird sites, okay? People are more educated than that. And I think right away, absolutely, there's no doubt in my mind, you have to be real, and you have to set realistic expectations, yet give some hope too. That's my
I think
it's so. Sorry, go ahead.
Go ahead. Well, I was going to say, I think that's part of the problem, is that we associate palliative care with hospice. We equate them in our minds, and they are not the same. But because we're so slow in correcting that, I think we haven't corrected that yet. Because I know that's what I heard was hospice, and I was not ready for that yet.
But don't you think it's difficult for physicians? I'm not one, but to say in the same sentence, have hope and have pessimist statements given in the same thing. I think it's an art. I work for 4 physicians who are here, and I think they do a great job. But I think it's hard. Is it hard as a parent to hear hope and?
Yeah.
Hope and comfort. I mean, that should be in the same breath, and that's how we need to introduce it. And it's so much easier being a non-oncologist for me to meet a family at time of diagnosis where it's already a stressful situation, but maybe there's little ways that I can impact that trajectory, maybe a little bit better pain symptom management up front, that really it's good buy-in for me as we journey along, maybe we'll make the journey a little bit less difficult. I think that there is something that we need to pause here. If we, as a palliative care doc, if you get involved up front, there's a huge workforce shortage. You know, there's projected to be 18,000 palliative care docs that aren't out there that need to be. And so we're working on it from a palliative care standpoint, but you know, there are challenges that not every hospital system has a peds palliative doc.
And to answer your question, unfortunately, not all physicians are created equal. I would hope that most of us in pediatrics did learn the art of, when you talk to family at the beginning, of yes, we want to be able to give some hope and comfort, but realism as well. And I personally think that's important.
Right, and there's hope for
don't know if any of my families are here that have actually seen me at the very beginning, but I know that's a tough thing to do, but you have to do it. And I also think that from a physician standpoint, that also is what creates our bond of trust, because families will go on the internet. They are going to find the information out. So at the very beginning, you have to be honest and upfront with the whole spectrum, depending on what that disease is, what the chances are, what we're working with. And that's important.
Right, and there's difference in terms of hope for up front, a complete cure, you know, and then as patients relapse, there's hope for, okay, if there's a 1 in 10 chance, we're going to hope that we're that one. We're going to hope for another year. We're going to hope for another birthday. We're going to hope for good quality time, pain-free time, hope that there's another cure coming out next year that we're going to be able to target, and, you know, we're going to get to that time point, and then hope for, you know, a peaceful passing and time at home with your siblings. There's different ways to look at hope, and there's always hope. And it's important to be able to have those discussions and really understand together where we are with our families. Sorry, Robin.
Go ahead. Dawn kind of said what I was going to say. Dr. Eslin did. I was just saying, up front would be wonderful, because then you really trust your team, and when you actually find out later that what they gave you was kind of bubble wrapped or just like sugar coated and not really true, you lose trust, and it's not good for you, it's not good for treatment. You look elsewhere, and then you're scrambling, and time is so important. And if they just told you in the beginning how important this time was, like, it would change everything. And if you just had like and maybe it doesn't have to come from the oncologist, maybe there is a way to like hire a staff that could be a part of that goal, like whether it be like the nutritionist and palliative care, that it's just a team that you trust from the beginning, and it really should be straight from the beginning, because losing trust in your team that's supposed to be helping you save your child's life really slows down the process, and then looking elsewhere is very scary. And so it would be nice from the beginning, at least, even if that hospital can't treat or doesn't do studies and stuff, if you know that from the beginning, it would really help.
I think too, to kind of touch a little bit on what Julie said, of, you know, wanting to hear from your physician, you know, there's hope and yet not. But I don't think I see it that way. I think it is because we know whether or not a therapy is likely to be curative, it's going to impact your child's quality of life. And so you're saying to them, not there's hope and there's not hope. You're saying to them there's hope, and then these things are going to likely happen, and we're going to try to control these symptoms and this impact this way by using this.
I have an answer to Dr. Eslin's question. I heard the word palliative in conjunction with my daughter Brooke's name for the first time on Thursday this past week, and it was before I came here. Dr. Scholler, would you be able to go back to the slide that has the diagram, the nice diagram with the curative hospice and then the curative palliative? Oh, I didn't know it was that far back. Oh, yes. Okay. So I was pulled into a meeting and asked by our home oncologist if I could please define the molecular guided therapy that my daughter is on as curative or palliative. Curative or palliative, and that would help them to determine whether or not to send us to Orlando with the starting of her next cycle. I didn't know how to answer that question because I'd never heard palliative care other than in context of end-of-life care. And so to see this model here made a lot of sense to me. It's not curative or palliative, it's both. And my question to the panel is we're talking about professional oncologists at our home hospital. I'm not aware if they have a palliative care oncologist on board or not. It's a 60-year-old hospital, but it's still relatively a small children's hospital. So my question is, what do you say, or what would you say, or anyone on the panel, what would you say to an oncologist who still has that mindset that palliative does fall under hospice and it's going to change the way they care for your child under a roadmap that's being sent from somewhere else? And how do you help them accept the more integrated care model?
So I'll take that one because I'm the only oncologist not also hospice or palliative care physician at the same time. Although I've done that a lot. Before Blaine actually joined us, it was primarily the pediatric oncology team that helped even other parts of our hospital with palliative care because no one else did it. But Blaine and I have had lots of discussions in the 2 years that he's joined us on those very topics. How do you introduce it, when, and why is an important breakthrough. And it's an evolving system that we finally have. We really do believe that it's a process that should start fairly early because there are lots of families who need the all-encompassing aspects, not just end-of-life care. So there's a big difference between it, and I think people should start to learn to define it that way. Hospice care is only one small part of palliative care. It is not the same. They are not equal parts. They are not equally the same. So palliative care encompasses much more than just hospice. So I think people should start thinking of it that way. We need to change the paradigm of what people think. And it's unfortunately true. There are lots of, even just pediatric hospitals, let alone adult hospitals, that don't have access to palliative care. So they don't yet have the mindset that things should be different. But I think when palliative care system comes into a hospital, when the powers that be recognize that it's important, and then physicians buy into it, then they start to understand that that really helps change the nature of how people respond to what's needed for overall care for children.
Thank you. And then I also was curious because on the one chart she had it, I didn't get to see it all, but pain, fatigue, nausea, depression, anxiety, all of these things that you had listed that you look for. And if a child has none of those things, then when an oncologist says to you, well, if it has to be palliative or curative, and that's going to be my decision as to how I'm going to proceed with your child's care, that becomes very concerning on the parent end as to almost like that you're not on the same level of thinking as the oncologist. And then that becomes like kind of coming back to the trust issue of, how and the communication between collaborations, which as the NMTRC expands and more hospitals and more oncologists are on board, I could see this as a rising issue coming back to that patient-centered care.
I try and answer the question because I do spend the majority of my time being an oncologist and a very minority of my time in the world of hospice care, but I take care of both, and that hospice care extends into the grieving process. Just from my own personal style, I probably, when you said, how should I answer this question, or how should I respond to my treating oncologist, my initial instinctive response would be to say, why does that matter? I don't know that it matters that one defines whether it's curative or palliative. What you're trying to do is provide your child with the best possible treatment as you see it, and because you've all educated yourself. So what you call it doesn't really matter. What I think the spirit of the comment came from are studies that have shown that perceptions about likelihood of response entering a phase 1 trial is skewed. That in the past, and these studies are probably a decade old now, that parents typically are misperceiving the intent behind a classic phase 1 study, which NMTRC isn't really classic, and at least as the MGT is, it's providing a different and a new approach to compensate for the fact that classic phase 1 studies have a couple of % chance of having any benefit whatsoever. So you do have to, on some level, maintain a good working relationship and communication with your primary center. But I think the spirit of the comment is, do you really understand, I think, the prognosis of your child? That's the awkward way that it got rephrased, I think, is they want to try and check and see, do you understand what the situation is? Which kind of ties into my other comment that I'm running, and I'm just mainly looking at one piece of this compared to the rest of the panel, which is we talk about introducing something at the time of diagnosis, but we have to start working on what that something is, because it's going to be different at every place. But not every place is blessed like Minnesota and San Diego with all these wonderful services. There are some centers, the majority of them probably, they don't have any of that. And I've heard already the relative importance of the physician in the level of communication. I think people, I got a little offended actually when Julie said she works for us. I don't see it that way at all. I don't think any of my partners do either. It's really a very collaborative environment where everybody has input.
I think she said with.
You said for. I keyed in.
Julie, I had
there
you
was
back.
no sincerity behind that comment. So, but people still need to hear from their curative team some helpful advice that shouldn't be prescriptive or paternalistic, but advice. You look into these people, they've been doing this for their whole life, and you really want these people to give you guidance with what they know and not necessarily prescribe it, but guidance in some of the decision making. So we have to define what this intervention is going to be for everybody who doesn't have all the services. And then the last piece, which is my narrower scope, is what happens when it becomes clear to the physician that cure is impossible. And we heard a terrible story about somebody dying in the ICU, and I took care of Don's child. There are some horrible stories out there of children who are suffering because a discussion hadn't happened about discontinuing curative therapy, which is probably different than the discussion about integrating palliative care. And how on earth are we going to do that if we can't figure out how to integrate all these wonderful things about nutrition and pain control and symptom control when it comes time to recognizing that the child isn't going to survive? How do you have that conversation early enough so that the children aren't getting put through unnecessary suffering? That also we need to talk about.
And the discussion that Jessica had with her doctor isn't the first time I've heard that. And I think as a referral center, an NMTRC phase 1 site, I think and as more patients come, we're going to hear this more from oncologists who are out there. And so I'd love to hear from the panel. And how can we, as a kind of phase 1 center, so most of the oncologists have had discussions with your child's not curative. Maybe some oncologists don't think the family should be traveling for phase 1 care, but the family feels strongly about traveling for phase 1 care. And we want to have a good relationship with the referring oncology team, as well, with the patients. And I mean, what would be best for the patient is if all of us work together. And how do we make that happen as a phase 1 program for the answers?
I think a useful tool would be if the family fills out this decision-making tool, they will write what has been offered for them, the risks, the benefits of each individual option, what's important to their child, what's important to the family, their support system, and there it will be in writing. It would be a nice tool to send back to the referring physician that this has been discussed and reviewed and thought out, and that's why the decision was made to pursue the phase 1 study, and then to follow up with that quality of life assessment. If on the phase 1 their quality of life is stable or improved, that's solid evidence that the phase 1 study is benefiting them, and if the symptoms are getting worse, it's solid evidence to the referring physician, to the family, to you, that perhaps it's not working.
How would families feel about filling that out?
I think it depends on when you fill it out.
When you're before coming to a phase 1 center.
I think that would be very helpful. You have to get the hospital. You have to get the hospital you're at willing to give you that.
We can get all the NMTR sites to do that.
Dr. Schiller.
As a parent choosing a phase 1 study, assume, I mean, I'm fully aware of what a phase 1 study means. When I come to her, I called her, when I spoke to you 2 years ago now. I'm with Dr. Eslin too, and still at Sloan. And I'm fully aware of what that means. But I have to know that I did everything. And I'm so thankful that you all are here and you have researched and all of your teams together, because at the end of the day, you know, Bella's a statistic, but she's my heart, and I have to know I did everything.
I just want to say, it's the language that's got to change. You know, just like you said, palliative and curative. Being a nurse, you know, the cure isn't necessarily a cure. It's just, this is their life, you know. And I worked in adult and pediatric bone marrow transplant, so children are always busy living, you know. And I think even the smallest child has a goal, whether it's to go home or whether it's to
be with your dog.
To be with your dog. That's the buy-in that I'm looking for, is if we can just, you know, I sound hokey pokey, but I know one day I'm going to make sense to somebody. And, but I mean, I've had kids as little as 2 years old, and I will never forget when he brought me in a picture of all the blood cells. The hemoglobin was a mother carrying like the groceries and the oxygen and the nutrients. The white cells were like an army, and there was like a captain, and he was 2 years old, you know, and he knew how to change a dressing better than anybody that I know, you know. And he's I don't know, he's like 12 or 13 today, you know, and we're survivors, and I just don't want to underestimate the power of the kids. And you know, that's the biggest message, is like Dr. Smith has always shown me that it's important that they don't suffer, you know. And like being in between the physician and the family, there is something that gets lost in translation. And doctors are passionate about what they do, parents are passionate about their children, and the language just has to change. And I think it's just a bridge, and I think that's what this is all about. We're building a bridge between what people think we're going to do to their kids because they're in the study, and because that's what I hear parents say, that their kid's a guinea pig, but the reality is that they're not a guinea pig. They're a piece of that hope. I look at them as part of the cure, and neuroblastoma to me is like the new leukemia. And like 30 years ago, the cure rates and the therapies that were done back then, y'all are pretty much sitting in the same seat.
I mean, I'm thankful for more time.
Yeah.
I mean, I'm just so thankful for everyone here today for giving us more time. Sorry. 4 years ago, we were given a few months. And she's 4 years old, and you'll see her on Thursday, and she's going to dance up and down your halls. And you'd think that she was a very healthy bald child.
I just wanted to say real quick, you said, you know, that the wording needs to change so that it's not perceived so differently. And I think when we're talking about these children, they're not dying with cancer, they're living with cancer. And children very much live all the way until they can't. And so I think that's a great phrase that parents, that physicians could use to bring up what palliative care is. In comforting your child, and this is diagnosis, and your child will live with cancer, and to ameliorate side effects, these are some of the steps that can be taken to help them fight it, but live with cancer, not die with cancer.
I think, sorry, Jessica, just one little quick side note, because something you said I think is really important, and I think it's, I mean, everybody noticed it because you got a nice little round of applause there, because it's so, I think, so key, is that you need to know you did everything you could for your daughter. And I think all parents need to know that. And everything you could is different for each child because of their specific circumstances. I think we were blessed in that we had our doctors tell us that we did that. And so, you know, for the physicians that are here, that is really important to reinforce that when you are having the end of life discussions with your patients. That is really important for them to have that reassurance that your set of circumstances were different, but with those circumstances, you did everything you could. And so that was just my little side note. Thank you for bringing that up.
I just wanted to answer what Dr. Scholler had asked about the questionnaire. And I think from our experience, from the day that we were told Your daughter has stage 4 high-risk neuroblastoma. It is a poor prognosis. And here we have a phase 3 COG study. This is all we can offer at our home hospital, and this is all we have. And they explain it to you, and then you sign. Right then and there, I mean, it's just day 2, you know, then they're day 4, they started chemo, and it's just, that's it. And I feel like that, you know, if you knew then, and it was phase 3, you think parents that don't know phase 1, I mean, it's so unimaginable to think that a parent would sign and not know and not understand what a phase 1 or a phase 2 study meant, because I think, I know personally that I look at as many options that are out there as I can. I mean, I remember sitting with our doctors in New York City and learning about just tumor analysis and asking my doctor to email Dr. Merchant, and I'm just now meeting her today. But I mean, it's just initially looking and thinking about what your child has been through, what paths they've already taken, because even though you don't have it written down, you have a condensed version of your child's medical history because it's your child, and it helps you in decision making and looking at the options that are out there that are presented. And I think that there is resistance when you're coming from a home hospital that is not phase 1 or phase 2. I think that it's difficult for them to understand what you're interested in as a parent, and you know, kind of coming back to that quality of life sentiment.
One thing that I noticed so we had the fortunate and unfortunate circumstance of the fact that I was going through chemotherapy at the exact same time that our daughter was diagnosed, and we were on very similar drug regimens at the beginning. And because we were dealing with a 11-month-old, so not even a 1-month-old, who was diagnosed and going to be receiving chemotherapy, she was nonverbal, and basically you're guessing at side effects. However, I was already having them. So I was able to put my own side effects onto my child, and I took on the role of side effect manager. So even though, you know, she had her team of doctors who, you know, went through and decided what was best based on her tumors, she had a team of nurses who administered all that treatment and who made sure that she was safe in the way that it was administered. And my job was mom, but also side effect manager. And so that's what I took on. And so that was sort of the viewpoint that I had of, you know, my job as a parent. And one thing that I experienced was that a lot of times the way that side effects are managed with all these extra medications, you know, Zofran, Ativan, all these other things that are added into this regimen, the side effect medicines have their own side effects. So I remember when I was first on treatment, and they basically gave me tons of medication for side effect management, tons. And I got sicker from the side effect management than I did from the chemo. So I myself reduced the amount of side effect medication that I was taking and only took it based on what I really needed. Now that's different for everybody. So, you know, but I knew enough of my own self that I was able to adjust that accordingly. And I think when I used that on Saoirse and looked at her and said, okay, I'm only gonna give it to her if she really needs it, and sort of gauged her reaction, engaged her, you know, facial expressions, her mood, her, you know, sleeping habits, and gave her sort of just enough. It managed her symptoms in a way that kept her from being over-medicated to the point of extra symptoms. So one thing that I'm curious about is how could the sort of, I feel like that would be sort of the part of sort of palliative care, because that's really what palliative care is it's this side effect management, because everything is a side effect, because if you didn't have the treatment, they wouldn't be having these issues. So everything's a side effect. So how could the palliative care teams sort of work with the parents and let the parents, I wonder if that would be a way to sort of increase the efficacy of having these teams by working with the parents on this side effect management and calling it more of that at the beginning, maybe necessarily, so that the parents don't freak out with this word that they, you know, associate with death or hospice, or even just with this word that they don't know what it is, but everybody knows what a side effect is. And so, you know, once we got farther in her treatment, we were introduced to the PAC team, and, you know, they came in and they gave her all these medicines, you know, which unfortunately I wish that they would have discussed more with us, because they ended up affecting how she could be treated. She couldn't get certain treatments because she was on this medication for this side effect. And it wasn't made aware at the time that we were given, and then you're stuck with it. But, you know, if it could be integrated more at the beginning, if more options could be talked about not overdoing the side effect medications, if there's alternative ways to manage those, you know, using either Reiki or acupressure, or, you know, just like food necessarily, because a lot of times food can manage a lot of these the side effects, you know, nausea, and, you know, feeding. You know, we also used to make sure that they didn't run her chemo overnight, so that I could feed her while she was on chemotherapy, so that she wouldn't have an empty stomach, which led to less nausea, which led to less nausea medication, which managed her side effects better. So, you know, but not very many, because it's not nobody. Not very many people are lucky enough, and I say that and everybody's gonna go, I don't know if that's so lucky, but lucky enough to be dealing with it at the same time, to be able to say, yes, I know that, and, you know, when you give her vincristine, give her a mint pop because it tastes bad, it tastes like chewing metal, you know, like, that unfortunately doesn't happen. But if, you know, if it could be made more of sort of the parents' role, and it gives them this empowering role to say, you know, we're going to help you, we're going to give you these guidelines, we're going to help you manage the side effects, and then you can take that home with you. I wonder if that would be also a way to open up that at an earlier place in treatment, even if you don't have quite the amount of staffing that you would think you would need for it.
May I comment? Okay. This is all semantics, but what you described, and described perfectly, was family-centered care. And I think, is that the name of this? Yes. Parent-centered care. So that, perfect timing. Yeah, and at Rady Children's, we do parent-centered or family-centered rounding, and it may be similar to what you would envision, where in the morning, we have the medical staff, the resident, the fellow, the attending, round with the nurse. We get updated what happened overnight. Then the little team enters the patient's room where the parent is at the bedside, and we discuss what we just heard and run it by the parent and say, is this true? Your child vomited and you want to not give Ativan, but give Benadryl and Reglan, or do the schedule Zofran. So as a team, we come up with a plan based on, and the parent or the family has involvement as well. Does that sound like the model that you would envision?
Yeah, I mean, in a way. I mean, I think also just sort of making note available the options, I think, is a big part of it too, because a lot of times it's like, you know, A or B, but there are so many other, especially if you're looking at, you know, the whole picture of treatment, there are so many other things that can impact those side effects. It's not just, you know, Zofran or Ativan, which I think is what a lot of times you get in the institution setting. You know, it's like we have these 3 drugs that we know reduce nausea. Well, the fun thing is that the side effect of all of these drugs is dizziness, which makes you nauseous. So if you take too much, it just makes it worse. So, and that's my experience. And so the thing that I sort of wish was available was like something that was sort of give you all the options, not necessarily on the day that you needed it, but at a time when you could like process the different things that are available, so that it was more of like a discussion of like overall care, and not just like, today she puked, so let's do this or this. but more of, you know, if we can manage the nausea by using this overall change, we can use less of this, or we can better manage and make her more comfortable is really the goal.
Which I think Dr. Rubin could probably, I don't know if you can talk about that, or like when it comes to managing side effects of the drugs, which are nasty, they're really nasty side effects, any type of diet that I think parents would be made aware of that assist. Not necessarily replace, but assist. Saoirse's diet was a pretty good diet, and I think that it definitely helped, but that can't be tried and error. And matter of fact, I know it helped her. We backed off all the heavy medications and became side effects. We incorporated diet into it. It was very successful. So I'm hoping that with the panel and some of the things that we're talking about, that can be incorporated into not just, okay, well, we're here, she puked, we did this and this, but the overall has to be looked at. It's got to be.
Yeah, I'll comment on that. Well, certainly not everybody has access to a naturopathic physician locally, but I'm guessing that at the institutions they have access to some kind of nutrition department. So I think I don't know what the education is, certain nutritionists, but there's a lot of work being done. I mean, just looking at food sensitivities. You can do personalized food sensitivity testing just to see if somebody's actually having an antibody response to certain foods, which could create side effects, especially if that's the main part of their diet. And elimination of such could control side effects, not that you would even be able to predict, but just by putting them on an individualized food program based on testing, magic things happen sometimes. There are certainly the bigger food irritants out there, corn, wheat, soy, and dairy, which sometimes just a simple elimination of such is really helpful. And believe it or not, removing genetically modified foods from the patient's diet too produce changes that are sometimes amazing. It'll stop you in your tracks just by taking something away that they're continually eating. And so it's that practice of minimalization and not just giving more, but actually reducing something, which I think is what you're talking about, which is a great way to practice. So there's a lot of different diets out there, and you mentioned actually plant-based dieting, which is certainly a healthy way to go for some people, not for all people. And we've recognized that the dogma was for years is that move to a plant-based diet and to help you with a more durable remission, or it'll help you with A, B, or C. And we did that for years with people, and we found that there's just different metabolic types in people who actually need some animal product, but there's different quality of animal product too, which I'm sure you know, and I'm sure a lot of people you know too, that depending on how the animal is raised and killed, etc. And for instance, meat, or beef rather, just by changing from corn-fed beef to grass-fed and grass-finished beef is going to reduce the amount of omega-6 fatty acid, which is going to, you do that, you're going to shut down a lot of the leukotriene and thromboxane pathways, which from some of the stuff that was said here at the conference, reducing inflammation in the body, it's big. Not just from a symptomatic perspective or from a pain perspective, but also even from a molecular perspective and looking at some of the signal transduction pathways. And it's real. And it's something that you can sort of drizzle in all day, every day into the child. And you can, and that's it.
I totally hear you. You get so tired of medication upon medication to fix medication. My daughter had a little rash, and the doctor said, oh, put some hydrocortisone or whatever, hydrocortisone cream on it. And I asked, oh, great, will that heal it? No, it'll just stop the itching. And I thought internally, you're a doctor and you're not giving me something to help heal. I'm looking for something to help heal. And so you almost want a nutritionist or an herbalist or a dietitian, an oncology dietitian within every round that you go through, or a monthly meeting with your own specialized tumor board to bring in, because you have cancer, but you have a whole body, and the whole body needs to be working in conjunction with your immune system and the whole picture.
I have a question, just with the way that things are, like with Facebook and stuff like that, from a authority standpoint, do you have a website that maybe that these common questions can be posted by parents or experiences, like something that y'all would agree with,
to, but like a resource on the website where parents can post like whatever experience that you had or whatever nutritional recommendations you have that supports the consortium's goal. I'm just curious.
Yeah, and there is an NMTRC Facebook that. There is an NMTRC Facebook page where.
It's in a group too.
Yeah. Could discuss. Yep.
But Giselle, maybe something to think about as we're putting together the Kids Cloud portal
Yep,
to access to things like
Yep.
good links.
I'm just curious. I'm going to assume that you have patients that maybe don't get referred or have a hard time getting referred for phase 1 studies, because going back to your point, the phase 1 studies were always kind of bad medicine per se, not the best option for the patient. So how do you as a consortium present out to the community of doctors that what it's all about, what the concerns of the consortium are, how you treat these patients, so that any fears they may have about, a patient traveling for what they think of as a phase 1 from the past versus what these trials are trying to do, so that you can help increase enrollment, get more data, get more studies, and eventually help more children. So how do you do that from the hospice standpoint to all the questions that a home doctor might have, saying your child shouldn't be on care, your child shouldn't be traveling for care? How do you address those concerns so that more kids enroll and more doctors are willing to send them to a consortium they don't know anything about?
Right. I think this panel is one step in that process. I think we've heard a lot of those things from outside hospitals, or I really don't think this child should be traveling for phase 1 care. They really should be going on hospice. But that's not what the family wants. And can we provide the same level of care in terms of the palliative support that child needs, as well as the phase 1, and potentially that phase 1 might help with a response for that child, and they may live another 6 months and have another birthday. So I think this panel discussion that we've had today, and I think we're getting close to the end of it, is one step. I think we need to create from this a paper and kind of really looking at our, I love Annabeth's suggestion of really a living with cancer program, basically, not a palliative care program, a living with cancer program where we, at the time of meeting the patient, as Deb suggested, have an intake form to review the goals and hopes for that family. What are their goals and hopes, and how can we kind of help to meet those or not, and really and discuss that with the home oncologist, really letting them know that we do have full palliative care, supportive care at each of our centers, and that we are going to address symptom control management, having open discussions, as you mentioned, about what supports the family would like. Do we want to discuss naturopathic medicine? Are there supports in that area that might help? Massage, symptom control, what are the things we all need to discuss and talk about, not just TPI 287 or a particular drug, but discuss everything, and that we're really going to understand the holistic, everything about that child before they come to one of our centers, and we're going to communicate that back to the oncology team at that center and discuss it with the family. But I think that's something a phase 1 program really needs to have, especially in pediatrics.
And I think this group also, sorry, I have to break in, I have to head back to the airport in 1 minute, so I'll try and say what I need to say again. There's an opportunity to build upon what we do very poorly. And I've been at 3 different hospitals, all very good, and at each one of these hospitals I became more and more inspired to get into hospice care, because all of these people that I respected that had great worlds of knowledge all struggle with this same issue on how to discuss discontinuing cure therapy and decision-making. This decision-making tool I'm seeing as just a start of what we can accomplish here. It's out there, people have used it before, but there's still a gap in how we understand what the impact of a child getting diagnosed with cancer has on a family. It doesn't happen to a kid, it happens to a family, and the family's embedded in the community. And there are 3 different layers that affect. There's the child in the middle, then the family around that, then the community. And each family dynamic has different capabilities to be resilient in the face of adversity, and some risk into the family dynamics, some extra demands, some significant demands that are laid on them. And there is a social and a behavioral science out there about family resilience. The military uses these tools a lot. And if we can take an opportunity in the NMTRC to have a broader collaboration that traditionally has been seen in Children's Oncology Group, to use a tool that studies and integrates family resilience at the time of diagnosis, you probably teach and learn a lot about yourselves that you may not have known before this diagnosis, and they're definitely models of people who have risk exerted upon them, and the family actually gets stronger after they encounter some kind of risk, depending upon the capabilities of their family, of the individual, of the community around them, and all that support. So what I would see happening is maybe using the decision-making tool as just as a start, and building a whole family resilience model of care that is very different than anything else the oncology group, and applying the behavioral and social sciences on top of this. I think it will be able to push all of these discussions a little bit further, because there's still a disconnect between in the communication between people's goals.
And I want to add one more thing to that disconnect too, and it's okay if you have to leave while we're talking. That really there isn't a disconnect between what happened in the morning and what happened now either. And that's what makes the NMTRC different. I think so often all of us physicians have gone to those meetings where you have the morning that's all basic science, and the afternoon or the next day is all the clinical trials, and you're like, where was the connection? And so I think that's what makes this different, and that's what also gives us a semantics problem. There's a semantics problem with palliative care being both hospice and early treatment, intervention, symptom related. But there's also a problem with the phase 1. That NMTRC is not just your typical phase 1. A phase 1 is dose and safety for all comers. These are being chosen specifically with the neuroblastoma relapse population in mind. And so, I'm at a center where the only way that you can come see me is to get on a trial. So I deal with these issues very, very commonly. But the one thing that makes that different from our retrospective review of, what they do, like 15 years of phase 1 trials with 5% response rate, is that we're trying to use some of those genomics that you heard about earlier today to make it different. And I think it's incumbent on us to educate you guys and to educate your physicians sending to us that this isn't just the old school phase 1, the old school palliation. This is working personalized intervention to try to make an impact in your child's life in that N of 1 oncology setting. And that's my 2 cents.
And I think that's a great way to end, because I think when we do, I'm sorry,
No, I was thinking one thing that Pat said, and I'll be really quick. I think part of it too is that parents now, I think there's much more of a culture where it is becoming more acceptable for us to question. And so if you have a physician saying, okay, I think this child should be on hospice care, and I think it's becoming much more common that parents will go, why? What's it going to hurt if I bring my child to a phase 1 trial? Because there are really a lot of our kids don't have, maybe they are at the end of where a curative therapy is likely, but they don't have a lot of life-limiting symptoms at that point. Mm-hmm. Why not? And I think as, with social media becoming so much more commonplace, we're more connected to each other, and we can encourage each other to be able to say that, to our physicians. Why? What's it going to hurt to try this?
I think most physicians might actually listen to us, but our physicians didn't point into that. We had a block up at the time we talked about that. And I think that's a challenge, and Pat's right on the money. We need to figure out how to, our roadblock are physicians.
Yeah. Well, and Don, the same thing can be said for nutrition and naturopathic care as well. If a phase 1 won't hurt, why not? Why can't I try L-glutamine? Why can't I do licorice? Why can't we do, curcumin or whatever? Well, I don't know about it. Well, that's not a really good reason.
We look at it as 12 eyes, and that's a true story.
I would not be surprised at all if so many of your patients were putting pills down their child's mouth that the doctors do not know about. Many, many, many parents are doing what they can for their child and keeping it a secret from their doctor because they think they won't get the green light from their doctor.
Right, and I think that's a shame. I think as physicians, I think it's okay to say that we don't know, because we don't know everything. And that's definitely, and we can learn from hearing from the patients and then going and looking it up and talking to people who do know and finding the answer out for you or for us together as a team. But it's definitely has to be a team in caring for these children when we don't know the answer for the cure, but we all want to find that. And so we have three.
We got three still going.
You've been waiting the longest, and then Kathleen, and then Jason.
Just again back to that integrative caring model and listening to everybody about language and also talking about the side effects, things I agree with, and I was fortunate enough again to be introduced at the very beginning to all of this stuff, and it has made a world of difference. And so I was thinking, what if everybody approaches it, and if at that very first meeting I heard something like, I'm Dr. So-and-so, I want to let you know we're partners in creating the best quality of life and in battling out this cancer and living with cancer. We have the following things that we can look at medical solutions, we can look at alternative medicine things, we can look at this whole line. It's okay to push back. It's okay I want you to ask me if you don't understand something. And one thing our doctor always said to us is she said, it's okay to go to the internet. I want you to go to the internet, but then I want you to come see me. Because what's out there it can be scary, and I want us to talk through what you read. And it was from the get-go, we were always positioned as partners at the table. And I think one thing, when there's so much loss of control in a family system's life, to have someone from the beginning say, you have a voice. And just because you might not understand the first half of the symposium, we still know that you know what you're talking about and that you're an expert in your child. And to bring that out from the beginning, say the options, and say, even not just from the beginning, but every time, how would that change the mindset? If every time you did rounds, someone said, we're partners in looking at the best quality of life for your child right now. Is there anything we can do to improve the comfort and the care of your child today? And there's days I would have said, it'd be great if we scheduled the meds at the same time so I wouldn't have to wake up a sleeping baby. It was awesome that someone donated this little push car that I could push while I was dragging an IV because my son finally got out of the room. And those are little things because they are living with cancer and they're doing everything they can to kick its ass. And yes, I said that in a microphone. Those little things and that daily approach, not at the beginning and not in a point of crisis, but a daily approach from the parents and all the care providers, I think that could shift everything dramatically. And I appreciate the discussion that there are that everybody is weighing in on, because it's a total experience and everybody wants the same thing. But at the core of it, we want the respect and the dignity and the hope and the positivity that our children are bringing forth every single day. They bring their best game, and we've got to do right by them. So, thank you.
So I just wanted to make a quick comment to Pat, your question and some of the things we've experienced. And it's well described that primary quote-unquote physicians' perceptions can be an obstacle to early phase enrollment. And I think, one of my favorite things about this consortium is that the parents are such an integral part. And I think a lot of what you're asking is going to be driven by you, because we find ourselves in the position constantly reminding oncologists that, guess what, this isn't about you. This isn't about you giving up control. This isn't about you referring. It's about the kid and what the family wants. And so I think if you as parents and as families continue to drive that forward, that, that can advance things much more quickly than we as providers can.
Okay, Jason, one more comment? And then
Just a brief 2 comments. And first of all, this is an incredible panel discussion, and I feel like I really need to apologize to Annabeth for all the physicians who took care of your child. Because, in medical school we learn the very first day, do no harm, and also that it takes a team and it takes a village to take care of these kids. And I think that a good test for any family who has a child with cancer is ask their oncologist, I want a second opinion, and see what they say. And like at our
research CPS.
Right. At our hospital, I mean, so we offer second opinions like, all the time from people all around the country, and there should never be like there's the arrogant physician is something that really has to be kind of actively opposed in terms of a culture, especially now that palliative care is kind of out of the 20th century and into the 21st century. And I think, our parents the children teach us every day how to take care of them. And if your physicians if you don't see that in your physician, just walk away, go to another hospital. And the administration of my hospital probably doesn't like to hear that, but actually they do. At Texas Children's, it's very open. We have a very we go right from the inpatient service to the phase 1 trial. The research protocols. It's all integrated, and there isn't a barrier between phases of therapy. And more, I think that's the way hospitals should be designed. And the other thing is, I think, just to give the doctors a little bit of credit, they really, I think every physician who loses a child takes it as a personal failure, and it's really hard when you're, one of the barriers to having that discussion with the family, and the reason we don't have that earlier, I think, is that, when we have to say, well, I don't think we can cure your child, it's like, years of training and tools and learning how to take care of these patients. We're saying, well, basically, we're complete losers, and we're total failures for you, and we're not coming through. And admitting that is really hard for the physician. And I think that there are a lot of barriers to physicians having conversations that, from the doctor's side, that we as a profession have to address. And parents really, I hate to hear stories about parents suffering from our shortcomings. So I'll just end right there.
And I think this panel discussion hopefully is one step to correcting those and to helping us all take better care of your kids, and forming our Living with Cancer program at the NMTRC. But first step.